Hi, my name is Elizabeth On, and I'll be presenting on gaps in healthcare among Peru's refugee and migrant population. Through my school's global studies research concentration, I've spent the past 3 years researching the Venezuelan exodus, along with the response of host countries in the LAC region. Using Peru as a case study, along with reports from UNHCR, UNICEF, and the IOM, this presentation more specifically examines the consequences when the state's domestic agenda clashes with non-governmental humanitarian efforts in migrant health, as well as the impact on the accessibility of healthcare for this population. So, a little bit about me. I'm a rising senior at the Potomac School in Virginia. Some of my experience in public health and research includes, as I previously mentioned, being a member of my school's research concentration, which I began as a sophomore. And last summer, I interned at NYU under Medical Ethics Senior Research Associate Lisa Kearns. And for the past 3 years, I've shadowed at the New York Presbyterian Hospital, including surgical operations and wound care rounds in the burn unit. And finally, I've done research on the correlations of thriving child labor, poverty rates, and educational attainment, which was published in the EduLearn 24 conference proceedings in the International Academy of Technology, Education, and Development Digital Library. In the future, I hope to continue my studies in healthcare for vulnerable populations, whether it be through law, policy, or clinical work. So here's a brief overview of my presentation, beginning with some background information, followed by a timeline of humanitarian efforts in promoting equitable healthcare for migrants and refugees, and then a more in-depth exploration of the conflicting relationship between the state and non-governmental humanitarian actors, which covers domestic migration and healthcare frameworks, as well as the resulting limitations on the distribution of medical aid, as well as the short and long-term consequences that ensue. And then finally, a brief conclusion. So for context, years of corruption and economic mismanagement in Venezuela under Hugo Chavez and his successor, Nicolas Maduro, manifested in extreme consequences for the Venezuelan people, as listed on the screen. First, looking at the proactive intervention stage in 2018, political pressure made it difficult for UNICEF to coordinate necessary resources and stakeholders in order to provide medical aid for this community. Specifically in response to the mass inflow of Venezuelans in 2018, UNICEF attempted to declare an L2 emergency, which is a moderate-level crisis that exceeds a country office's capacity to respond, requiring additional support from UNICEF's regional and headquarters offices. However, with the Venezuelan exodus becoming an increasingly politicized topic, especially with the media projecting narratives of criminalization and gang affiliation, this has sparked very polarizing views on the accommodation of Venezuelan refugees and migrants. And as a result, authorities have displayed unwillingness towards accepting UNICEF's proposals, as well as unwillingness to accept foreign aid. And so UNICEF reported great difficulty with convincing the state to declare the L2 emergency, with pressure from the state to limit international mobilization around the issue. And so ultimately, the L2 emergency wasn't achieved until 2019, and when it was activated, UNICEF was able to facilitate primary healthcare for thousands of women and children, as well as training hundreds of healthcare personnel, providing essential medical aid, which, although was clearly very impactful, UNICEF wasn't able to maximize the efficiency and urgency, essentially prolonging the suffering of the Venezuelan people. Here we see the humanitarian-centric agenda of UNICEF conflicting with the state's responsibility of accounting for public opinion, resulting in some pretty serious humanitarian consequences. Next, in 2020, the pandemic amplified health disparities for Venezuelans in Peru due to the erosion of migrant health protections during the pandemic. On the left is a quote from UNHCR, which states that due to the reduced mobility imposed by the emergency, the presence and activities of UNHCR and its partners, the Migration Office, and most importantly, health facilities, have been overwhelmed by COVID-19 cases. For context, the state imposed a nationwide state of emergency between March and October 2020, and under these restrictions, UNHCR wasn't able to operate at the capacity necessary to meet the volume of need among Venezuelan refugees and migrants, which had increased during the pandemic. And so, in an attempt to limit the spread of the virus, the state's strategy inadvertently barred about 75% of Venezuelans from COVID related care, like vaccines, medicine, and diagnosis. And this was because they didn't have the essential pathway of UNHCR, which many of them previously relied on. And this heightened the risk not only for the Venezuelan migrant population, but also the general public of Peru because of the transmissibility of the virus. Finally, between 2020 and the present, barriers to long-term health equity have persisted. As stated on the right, over 90% of Venezuelans in Peru lack access to comprehensive health insurance, also known as SIS. And 56% do not have proper documentation to access healthcare, and 88% are unable to pay for essential medical services. One of the main ways that UNHCR attempted to address these disparities was by expanding the eligibility criteria for SIS, including emergency cases and vulnerable groups like gender-based violence survivors, HIV patients, and the elderly. Previously, within the Venezuelan migrant population, only pregnant women and children under 5 qualified. While in theory this marked considerable progress, challenges arose especially as the Ministry of Health did not recognize medical reports from foreign countries, which acted as an obstacle in qualifying for SIS. And also looking at the system just as a whole, due to the vast majority of Venezuelans not having access to essential comprehensive healthcare, this has created a system dependent on international funding, meaning it is subject to donor priorities and overall insufficient to meet the volume of need. Furthermore, state restrictions have created a group of people perpetually reliant on external medical aid, which creates a continuous gap in health coverage and puts into question the sustainability of healthcare services that UNHCR and other non-state actors are providing. So, in conclusion, within the context of global health, this case underscores the importance of balancing state sovereignty with multilateral intervention in addressing the health disparities faced by refugees and migrants. And to ensure equitable healthcare policies, especially in response to large-scale displacement crises, both state and non-state actors must coordinate in designing and implementing effective policy solutions. Here are my references. And I would like to acknowledge the Potomac School History Department, REACT-DC, and Lisa Kearns for their guidance throughout the research process. And thank you. If you have any questions or would like to know more, please feel free to reach out with my email and LinkedIn on the slide.